Saying there's 4 people on right now, so I'll give it a few more minutes. Let's see. Cool. Do you think we should just start now? I think there's like 5 people on so far.
Yeah.
So welcome everyone. We're going to be just going through how to do an A2 exam and give you some OSCE tips and go through some cases, if that's okay. We'll have an eye on the YouTube chat as well, so put any questions you have on there. I'll just make this big screen as well. That's what I hope. Cool. So what we'll be going through is tips on how to score highly in OSCEs, just the breakdown of how to do an A2E assessment, including S-bar handover. We've also got a case and then some other common final scenarios that we think you should really revise for. Cool. So how to start your OSCEs. Most of you watching are probably final years, so I'd hope you know this already, but it's always important when you first go into the station, there'll always be a hand gel or like hand sanitizer there. Always use it. It's there for a reason, just use it. And show them that you can wash your hand. It's a tick box and you get an extra point for that. Introduce yourself, introduce your role. So just be like, present yourself well and friendly, and that you'll score points for that as well. Always important to confirm your patient's identity, including their name, date of birth, check their wristband, and if you've got any piece of paper as part of this scenario, so like a drug card or just a bit of history, compare their wristband to what's the name and date of birth is on there, basically. So if there is anything to utilise in the station, use it. And then that just shows the examiner that you're aware in the hospital that you need to be comparing your notes to the patient, what they say, and to their wristband. Then obviously explain what you're about to do. So for this, it would be an A2E, and just explain just a quick head to toe examination of you and take a quick history, etc. And then gain consent. So explain what you're going to need to do, like I'm going to need to listen to your chest and examine your body, etc. And always get consent. And then finally, just clarify any questions before starting. Just give the patient that opportunity to ask anything, makes them feel more comfortable, makes you seem like a nice, caring person if you ask them, and give them the opportunity to speak back to you. And then make sure they're in appropriate positioning, so get them laying on the bed, it's most ideal. And then also offer them a chaperone if it's required. For an A2E initially, you probably don't need one, but if you're thinking, if there's a situation where you think you're going to have to do an intimate exam, always offer a chaperone. Maybe don't even offer, just say there will be a chaperone. It's normally easier to just present it like that. So yeah, in the scenario, you might be, different unis do it differently, but you might be given a piece of paper that has a brief history on it. That just guides you slightly of where the scenario might take you. You might also be given like a drug card, so have a quick look over that and see what medication they've already on, what they've had, and their allergies, because that might give you a bit of a hint of which way you need to go down, basically. And then any other equipment, always look out what's on the bedside, because it might give you a hint that if it's there, you should be using it. So if this is separate, but if you were to be doing a DVT examination, if there's a measuring tape, use the measuring tape. Things like that. People get caught out. They look at it and think it's a trick, but most of the time, equipment is there for you to use. So I'll pass on to Jack.
So just starting off with the AT assessment of the airway. So the first thing to ask is, you can either ask the patient directly, you can just speak to them, or you can ask the examiner. So it kind of depends on how they're doing the station. But if you just ask if the patient's talking, you can gain quite a lot of information from that. So if the patient's not talking at all, that's obviously quite a worrying sign that their airway might be occluded. If they're talking in kind of shorter sentences as well, that might give you a hint that maybe they're having a breathing problem, such as an acute asthma flare-up. So you can get quite a lot of information from that. So some of the common reasons that the airway might be obstructed. So the patient might have vomit or blood in the airway. Another common one is the tongue obstructing the airway. So in someone who's got a low GCS, the tongue can kind of pull back and occlude the airway. So you get a blockage there. And what you want to do when you're starting this station is kind of make it obvious that you're looking to see if the airway is open. So by asking the question, you're ticking that box basically, and then you're make it obvious that you're maybe looking for signs of obstruction, and you can actually look in the patient's mouth, listening out for any stridor or any secretions as well. And the kind of immediate management for airway problems. So just starting off with a simple one. So if the patient's kind of not talking to you in full sentences, or you have any kind of concern that the airway might be compromised, so they're maybe mumbling or making gurgling sounds, the first thing that you can do, and I'd recommend actually doing it in the OSCE as well. So don't just say that you'd do it. If you've got a mannequin there, then actually kind of acting it out is really useful. So head tilt, chin lift. The only caveat to that is that if the scenario tells you beforehand that the patient's kind of got a neck injury, then I would avoid doing that, and I'd do a jaw thrust as well. And then if you think there's something in the airway, so blood, vomit, anything like that, you can position the patient on their side if they're not injured, and sometimes they might have it in the station, they might have the suction there, or you can just say, I would try and perform suction now to remove the fluid. And then I would actually ask the examiner, okay, is the airway patent now? And you can kind of check throughout the examination. If there's still some issues, you can use some airway devices. So the OP airway or the nasopharyngeal. So we've got a picture here. This is how you actually measure the OP airway. So from the edge of the mouth to the mandible, and you can pick the right size. So there's, I think, 3 different colors, depending on the size of the jaw, which can be useful. And then you want to think about high flow option as well if the patient's airway is obstructed. And the most important thing is, if you've got an airway issue, you're probably going to need help. As I assume you'll be an F1 in the scenario. So the ways that you can do that is you can say, okay, I would pull the emergency buzzer in the room to get immediate help, to get more people there. And then you can also say, I'd put out at my hospital, it's 2222 call. So that just puts out like a general call to everyone. And then you can say, I'd put out an arrest call or a medical emergency call, depending on kind of what's going on. And then, so once you've assessed the airway and you're kind of happy, so you've got maybe the patient's airway is a bit more under control, Then you can move on to breathing. And the way to do this is to kind of go systematically through. So check the rest rate. And I would say that you're going to check it for a full minute, because the rest rate can vary. So if you only check for 15 seconds, you might not get an accurate measurement. Usually they'll have kind of an OBS machine there already with the patient hooked up to it, so you can check the O2 sats, but if not, you can just either ask for it or put the sats probe on. Check the trachea, and like I would actually just visibly do that, so just check that it's in the middle. Check for chest expansion as well, so just putting your hands around the chest to check that it's even on both sides. Percussion, and then auscultation as well. And yeah, the image here is chest x-ray. That probably shouldn't have happened, but you can see that the trachea is deviated to the other side, so, and there's no lung markings on this side, so this is a tension pneumothorax. And then immediate management. So something that I got confused about when I was preparing for the finals OSCE is when to use 15 litres for patients that are acutely unwell. And the guidelines say now that you should just use it for, so anyone who's acutely unwell in these scenarios, you should just use 15 litres straight away, even if they have COPD. And I've got the BTS guidelines here. So in these guidelines, it says if the patient's acutely unwell and they have an oxygen requirement, what do you do? So basically everyone gets 15 litres, and then once you're stabilised, you can think about titrating the oxygen down to 88 to 92. But it's more important to kind of make sure that the patient's oxygenated first. Getting a chest x-ray is always pretty useful in these scenarios. ABG as well. And then depending on the scenario, so if you had something that you thought might be an asthma attack, you could ask for a peak flow. And then they might actually give you the x-ray, the ABG and the peak flow to look at and analyze in the station. But sometimes they won't give it to you straight away, so you can just do your assessment and move on to the next step, which is circulation. Sorry. So the way that I did this was that I kind of imagine that I'm going around the patient in kind of like a C shape, just to kind of help me remember to do everything. So if you start at the patient's hand, so you'll be on the patient will be on your right side probably. So you start by looking at the hands, so the colour of the hands. So are they kind of blue? Are they mottled, which could suggest sepsis? Are they cold? And then check the cap refill time. So to do that, you just hold down the patient's nail bed for 5 seconds, and then you're looking to see if the blood comes back to the nail bed in less than 2 seconds. So for the OSCE, I would also just make it obvious that you're doing that and say to the examiner, I'm checking the cap refill time. I think it's useful to actually just speak out all your actions in the A2E station, and then go up from the hands and do the radial pulse. And you can say, I would normally check this for a minute, and then hopefully the examiner just tells you to kind of move on to the next step. Offer to check the blood pressure as well. It's usually kind of on the OBS machine. And then moving up from the arm to the neck, so check the patient's JVP. So ask them to move the head to the left-hand side if they're able to, and see if their JVP is elevated, which can be a sign of fluid overload or right heart strain. And then you can also check things like mucous membranes quickly. Just say patient appears to be dry or appears to have moist mucous membranes. And then move down to check the heart sounds. So some of the mannequins that they have, depending on your med school, will actually have heart sounds as well. So you can look for checking that they've got like a normal rhythm, no added heart sounds, murmurs, things like that. I don't think they'll kind of be expecting you to diagnose anything particularly difficult during an A2E station. It's kind of just showing that you know to look for heart sounds and to make sure that there's nothing completely out of the ordinary. And then something you can also check as well, if the patient have to be catheterized is urine output, which is one that people actually forget quite a lot. So particularly in kind of like sepsis or an AKI kind of picture, it can be really useful to know patient's urine output. And then the immediate management and investigations for circulation. So making sure that you've got 2 cannulas on either side is probably the best first step. Making sure that you specify that you want a large bore cannula. So that means the gauge is actually in reverse order. So the smaller gauge of the cannula, the larger the lumen of the actual cannula. So essentially, the more fluid you can get to the patient in a shorter amount of time. So usually, you can try and get a grey cannula, and you can say, or just say in the exam, try and get 2 cannulas as large as possible. And then from that cannula, just take the routine set of bloods and a BVG as well. They might actually show you the gas in the station, which is quite useful because you can look at the lactate, you can look at electrolytes and see what's going on. And then you can also, if the scenario is kind of sepsis or something like that, you might want to take some cultures. If the patient's hypotensive, you can give fluid bolus through the cannula as well. And then you can also do an ECG depending on the scenario. And yeah, I'll just hand over to Jess for this bit.
So next is disability. So for this one, you're assessing like the patient's level of consciousness, depending on what your preference is and how well you know your GCS is either do AVPU or GCS. GCS, you do eye-opening, verbal response, motor, and then depending on that, they get their score out of 15. Big rule to note is if their GCS is less than 8, then you need to be calling anaesthetics because they're at risk of airway compromise. In an OSCE, if you say, I want to do GCS, the examiner might hit you with the, okay, well, like they're eye-opening to sound, they're a bit confused and they're localizing to pain, and they expect you to work it out from there. But that would be quite harsh, I think, to try and work it out on the spot purely from memory, but you might be expected to. Different universities have different requirements. Things people forget a lot is pupils, and pupils can actually tell you quite a lot. You want to assess the size, symmetry, and then how reactive they are to light. So with size-wise, if you've got teeny tiny pupils, like pinpoint pupils, you might be thinking this could be an opioid overdose. Oh, sorry, it's this bit. There we go. Yeah, opioid overdose. And then if your pupils are different sizes, then you might be thinking there's raised intracranial pressure due to bleed, stroke, anything really that can cause that. So you want to be ruling that out as well. And then reactivity to light is if they're sluggish, the response, it might mean they're coning or they're about to arrest. BMs is if, is classic, don't ever forget glucose to finish off your A2E. That tells you a lot. If they're hypoglycemic, they'll have a reduced consciousness. So that's a quick, all you need to do is a normal BM and you've kind of identified the source of the issue pretty quickly. Always important to do a brief neuro exam. Obviously, if someone's got a low GCS and they're basically flat, you're not going to be able to examine this. But if someone's conscious but slurring their speech or has facial droop or saying they can't move their arm, do a very quick neuro exam, and then you're looking at more like, oh, we need to get this person to CT. And then medication history, like I said, I mentioned opioids earlier with pinpoint pupil. If there's a chart, look at it, and then that might identify why their level of consciousness might be reduced or affected depending on what medication they've actually either normally are on or have received for the first time. And that's, yeah. Oh, sorry, I don't know how to move it on. There we go. So investigations for disability, head CT, if anyone's got a new acute change in consciousness, like reduced GCS, complaining of new onset headache, confusion, etc., take them to head CT, especially if they've had any falls or trauma, which in our hospital happens quite a lot. Blood glucose, like I said, and while you're doing blood glucose, you might as well do your ketones. You'll have done an ABG when you're assessing B/C. Always good to look at the CO2 and lactate for that, just because with CO2, if that's increased, that can make someone narcosed. You're probably already on the hint because you would have covered that in B anyway, but if that's the case. But yeah, raised CO2 can reduce someone's GCS. And then lactate, if you were doing an A2E post someone having a seizure or something, then the lactate would be raised. Also, if you're suspecting sepsis, lactate would be raised. So again, it can point you in directions with that. And then drug charts, like I said, any opioids, any sedatives, any like anti-anxiety medications like your benzos, your SSRIs, things like that, that can affect your consciousness and disability. And then I don't actually know if anyone's on the chat or if anyone's willing to say anything, but can anyone identify what's happening on the image, like more in the center, the one to the left of the screen? I know there's a bit of a delay, so I'll just wait a few minutes, and if not, I'll just talk them through. Okay. Oh no, it's just Jack. Yeah, I'll just talk them through. Might be easier. So this is in the middle of the screen is an extradural hematoma. So how I always remember it is extradural is a lemon shape, and then subdural is a banana. This is really throwing me back to my finals from a year ago knowledge, but an extradural is normally from trauma. Normally the history is a classic. Someone's been hit in the head, they go down for a few seconds, they lose consciousness, and then they wake up and they're fine, and then all of a sudden they deteriorate after about half an hour or so. And then a subdural is more of a gradual thing, is someone has, again, sometimes hit a head, sometimes it's spontaneous, common in elderly people and people who drink lots of alcohol. If they've more of a gentle bump their head, less traumatic normally, and then gradually have become more confused over a certain amount of time. And then you'll find that how they're treated is different. Classic, if you see these, if they're on a DOAC or on any sort of anticoagulation, stop that straight away, and if possible, reverse it. So like vitamin K for warfarin, and then there's some more fancier ones that most hospitals don't actually have because they're more expensive for DOACs, but I can't remember them off my top of the head, never seen them used in practice really. But and then you just need a neurosurgical review. As a F1, you wouldn't be expected to ever actually be the person to treat it or fix the problem, but you'd refer on to neurosurgeons. But yeah, I'll move on to exposure. So exposure / everything else is pretty wishy-washy. You're basically looking, if you haven't yet identified a problem, you're looking for anything else it could possibly be. Some people do temperature in disability. Honestly, it doesn't matter. You could do it in either. So if they're hypothermic, hypothermic. Rashes, so say they've got a non-blanching rash, you're looking at more like meningococcal meningitis, sorry. Bruising trauma, so if they've come in from a road traffic collision, then you're looking for if they've got any broken limbs anywhere, any areas of pain, any obvious bruising that you want to get x-rayed straight away. Surgical scars, so if you're assessing someone who's had any recent surgeries, basically take off, if they've got any bandaging over the surgical scars, take that off, have a look if it's infected or if the site looks not quite right. Signs of DVT, so unilateral leg swelling, erythema in the calf. Medical devices, so if you're already suspecting that someone, if they're a known diabetic and that someone's maybe having hypoglycemia or hyperglycemia, but you've not yet managed to source because this happens in practice a lot, a BM machine, see if they've got a pump or something, and pump might say failure or it's a high rate. So basically just check these. Some people have implantable devices as well, just check over them. And then fluid balance, Jack mentioned earlier, but if you've forgotten it in C, then you can always do fluid balance. Do they look dehydrated? Do they look overloaded? Because normally in E, people start looking at people's legs. So if they're peripherally overloaded in their legs, you might be suspecting that they might be overloaded. And then, so I've also put a slide on for what to do if someone is bleeding and having a major hemorrhage. So this is the only case which you actually don't start with airway and you'd address the bleeding first, rather than protecting the airway, because basically if you don't control that bleeding as soon as possible, they're going to die. With a catastrophic bleeding, that is the whole how much bleeding they've lost. I think it's like more than 50% of their total blood volume in a certain amount of time, a couple of hours, I think. But I can't lie, if you walk into a situation where you see a catastrophic bleed, you kind of instantly know what's going on. You see it. There's no point trying to be like, oh, is it 300 mils, 500 mils, etc. If you see it, put out a major hemorrhage, cool. No one's going to ever have a go at you for putting one out if they're not meeting the requirements, basically. So normally if I just see bleeding and someone is also hemodynamically unstable and scoring on their news, I will put out a major hemorrhage and then get senior support straight away, because it's better to be safe than sorry. So you put out the call for help as soon as possible, and normally most hospitals have the protocol of if once you put it out, it goes straight to blood bank. A porter will be on their way with a lot of blood and blood products. If you can see the area that's bleeding, so like an injury, direct pressure. If you've got equipment that you can use, so like proper dressings, like suction dressings, things like that, use it. Elevate the limb if that's appropriate. Most commonly in hospital, it seems to be upper GI bleeds or PR bleeds that I've experienced, rather than like an actual wound. So with these, you obviously just can't stop the bleeding. You need gastro involved for that. So again, you can alert them if you can see that that's the clear source of bleeding, alert them. These are more about trauma things, but tourniquet or pelvic binder if possible. And then, so this is kind of part of your C in your A to E, but you're prioritizing C first, basically. And you're wanting to get 2 large bore cannulas in, and you want to be sending a full blood count, clotting, cross-match, group and save, etc. as soon as possible. You don't actually need these before doing the major hemorrhage protocol, because anyone just gets own egg blood because it's an emergency. So you don't wait for these results, but it's good because these people probably will need multiple transfusions, so it's good to have them sent off as soon as possible. And then TXA, so that's tranexamic acid, within 3 hours. Most people just give it straight away in major trauma. And there's been some papers on it. I can't remember the exact paper name, but there's a famous trial that's proven that it makes a difference. Cool. So I'll go through the case, and then I don't know if anyone's actually going to interact. I can see people are on, but hopefully people might interact. So you're an F1 on AMU, a 64-year-old female, day 5 post total hip replacement, has suddenly become breathless. Her OBS are rest rate 30, SATs have dropped to 88% on air, heart rate's 118, blood pressure's 102/64, temperature's 36.8. She's alert and feels anxious. You've never treated this patient before, so you don't know anything about that history, or other than the fact they're in with a total hip replacement. So what would be people's first steps? I'll give it a few minutes to let people answer, but if not, I'll just walk it through. Okay, I don't think anyone wants to answer today. So I'll just walk it through basically. So with that, I think because the patient, you can tell, it's a new, their oxygen's dropped, so they're going to need new oxygen requirement. Their rest rate's high, their heart rate's high, as well as their blood pressure. They're slightly hypertensive. You're going to need to do an A to E before you do anything else, basically, and then fix as you go along. So with you do the A, you know they're alert, they're talking, so you don't need to worry about that airway too much. B, their SATs have dropped, therefore start them on oxygen. Better to start them on oxygen and find out later that they have COPD, etc. Just because it's an emergency. So I'd start them on a 15-litre non-rebreathe and then try and wean it down from there, basically. And then blood pressure, you might want to consider a fluid bolus. Have a look at what their blood pressure had been throughout the day, because if they've been sitting around 100 systolic all day, it's probably just their normal blood pressure. But if they normally sit around 140 and it's dropped to 100, then you want to be starting fluid resuscitation. It's more about the trend in numbers than the actual numbers, if that makes sense. And then, there's limited information. And then just do your D and your E. So differentials for this, sudden breathlessness, would be PE, pneumothorax, ACS, acute heart failure. So you'd be asking them, are you having any chest pain? You'd be listening to them, making sure there's equal air entry. If they've reduced sounds in their bases, if they sound like if their lungs sound fluid overloaded. But yeah, I've already talked through the A to E part. And then in E is where you'd find the fact that they have a possible unilateral leg swelling. And I think at this point you'd want to get a CTPA. You wouldn't, they'd qualify for going straight for a scan rather than doing anything like a D-dimer. Not that I would do D-dimers in practice that often, to be honest. Does anyone know what makes her a risk of having, I know no one wants to really answer questions, but anyone know why she's at risk of having a PE or a DVT? While I wait for an answer, I'll just talk through as well. Also, because hospitals have lots of delays and no one ever can get to scan that fast unless they're acutely unwell, I would start, depending on your hospital protocol, I would start someone, if I'm suspecting a PE, DVT straight away, I'd rather start them on TINs and wait till later to stop it again than wait for the scan to confirm it. So I would just start them on treatment dose. And no one's answered. So her risk factor is the fact she's day 5 post-op with hip replacement. She, depending on protocol in different hospitals, there might have been a couple of days where they don't do, I've never done an ortho placement, so I'm not entirely sure, but she might have not had her low molecular weight heparin. She might have normally always been on a DOAC and someone's forgotten to prescribe it. Lots of things like that happen in hospitals. Therefore, the fact she's just had an operation, she might be more dehydrated, she's not been moving around as much, therefore she's at higher risk of having a DVT and a PE. So you want to be starting treatment dose anticoag as soon as possible, basically. And if they were hemodynamically unstable, you'd be thinking about thrombectomies, IV, heparin, things like that. But that is for a senior to decide, not you guys. Cool. Jack, do you want to go over SBAR?
Yeah, sure. So this, let me just pop that up. So the SBAR component might be kind of a separate station. I remember in some of my OSCEs throughout the years, I think we had just an SBAR station, but a lot of the time it'd be kind of the end part of the A2E station, and it's kind of what you do when you're handing over to someone. So maybe the med reg or the senior, so the anaesthetic team that have come to help out. And you can basically use this to kind of give a quick overview of what's happened. It's not about giving all the information, it's kind of highlighting the most important bits. And if you think from the perspective of kind of a med reg or a busy anaesthetist, they've probably got quite a lot going on. So the immediate thing that you want to do when you're starting this is give the situation and say what you're most worried about. So in our example, you say, I'm the F1 doctor on call. Can I just clarify who I'm speaking to? And then the basic details about the patient. So they're on syringa ward, and I'm quite worried that they've got a PE. So just immediately say like why you're calling. And then you can kind of give a bit of a background of the patient. So she is post-op, 5 days post-op, and say kind of if they've got any past medical history or anything that might contribute to it. Are they on any kind of medications? So maybe the contraceptive pill, something like that, that might be useful. But it's not about giving all of the information available. It's just the most important. And then go on to talk about assessment as well. So just a quick overview of the A2E. So you can say she's sat up, she's alert, but she's anxious, her airway's patent, the chest is clear, but she's hypoxic, she's 88% SATs. You can mention maybe fast respirate, she's tachypneic, she's tachycardic on examination, blood pressure is 102 over 84, whatever it was. So just give a quick overview, and then say she's alert and she's got some calf swelling as well, just to kind of highlight the most important bit. And you can also say if you've already ordered any of the tests. So you can say, I've ordered the CTPA, just waiting for the results. We've got an ABG, which shows type 1 respiratory failure. Which is basically just a quick overview. And then for the recommendation section, you want to just say what you want the person to do. So in this case, for the medical registrar, we'd like you to come and see the patient as soon as possible, and then hopefully they'll agree. And yeah, they'll come and see the patient. So like I said, that can actually be a station on its own, or it can be kind of just put onto the end of the A2E station. But it is quite hard to do on the spot, so it's something that's worth practicing. And the way that I practiced for this was just if you're preparing with someone on the course or something, you can get them to just give you some information and just make sure that you can quickly relay the important things back to them. Or you can actually use AI. So I think Geeky Medics and a couple of the other websites have AI features now that you can practice with. And this is one of the stations on there, so it's quite good for that. And then just some general tips for how to score just highly in the OSCE station for the A to E. So when you're going through everything, make sure to kind of speak out loud, it's especially important in this OSCE station. I think some of the other ones are a bit different, and the med school that I went to, they kind of gave us the option. They said, oh, you can either speak to the patient as you would in the normal clinical setting, or you can say your findings out loud and things like that. But for this one, I would say making sure that you're like saying you're checking the airway, checking breathing, just to signpost that you've gone through everything. That's how I did it anyway. And then clinical competence. So what I meant by that is just, I think people can tell if you've been at placement or not, if you've actually gone to the hospital. So I remember some of the feedback from one of my OSCEs was that some positive feedback was that I remembered for the non-rebreathe mask, you need to hold the valve while you're inflating it so that you can make sure that the reservoir bag actually fills up. So just things like that, actually do them and just show that you know what you're doing. Do the head tilt chin lift. Say that you would use the emergency buzzer as well, because I think that's something that gets forgotten quite a lot, just to get people to the bedside quickly, and then escalate early as well. Because the safety and the kind of escalation is the most key thing, and they just kind of want to see that you're safe as an F1, not expecting you to solve all of the issues that come up in the ATE. It's just making sure that you can keep the patient stable and escalate to the appropriate people, and then treat as you go. So if someone's hypoxic, don't move on to C until you've started the oxygen, basically. I think it can be quite easy to kind of forget that stuff when you're in a rush or you're stressed. So just sticking to the structure, making sure that you've treated and done the investigations before you move on is really helpful. And then reassess. So you can do this either after each section. So say you've started oxygen, you can then say, what are the saturations now? Or you can do your A2E assessment, and kind of once you've got to the end, you could say, okay, now I'd go back and reassess the patient. So I'd start again with the A2E. And it usually won't make you kind of do the whole thing again. They'll just say, okay, the patient's now saturating 94%, for example. And when you're doing an SBAR, you can also feed that information back to the senior. So you can say, after the interventions, these are their new observations now. And then, these are just some of the common scenarios that I could think of that are the most likely to come up in finals. Sepsis is a big one. That was quite common at my med school. Major hemorrhage that we talked about earlier. Anaphylaxis, because that's quite an easy one to test. ACS, pulmonary edema, asthma, seizures, and then low GCS, which a common one they like to ask about is opioid overdose, because that again has some quite good signs that Jess talked about earlier. Don't know if you would add anything else to this list, Jess, but I think these are kind of the main ones. And if you go back onto the Mind the Bleep YouTube channel, our last teaching session, which was common A&E presentations, we covered the management of most of this anyway. So it's when you're advising, it's useful to kind of already know what you would do in the ATE for each situation, so that you're not kind of put on the spot for the exam. But I think these are the main ones, unless you have any suggestions, Jess. But
no, I'd say they're the main ones. I'd say.
Yeah.
They're all pretty common. I'd say I probably had nearly all of them at some point as an OSCE.
Yeah.
Lastly is just if you guys have any questions, I've just popped a feedback form link, as well as there's the QR code if you want to scan. If you guys have any questions, put them in the group chat now. We'll wait around for a few more minutes. I think my advice with OSCEs is, know your knowledge, and you're going to have to know your knowledge. But I honestly do believe 50% of it is how you come across to the examiner. I think if you can come across confident but not arrogant, and just as a nice person, if you're not like mumbling your words, if you're actually just presenting yourself quite well and quite confidently, that's going to score you the top marks and is going to give you a very good grade, basically, because most people can pass an OSCE from their knowledge. Because you're in final year now, you should know most things well. But if you want to be hitting those like top grades and like coming out of like top decile when you graduate, it's how you present yourself, basically. And I honestly think if you're just a nice person, it works in your favour. So that's my advice, is fake it till you make it, come across well, and you'll be fine. Even if you don't know anything or feel like you don't know anything, just fake it till you make it. But yeah, OSCEs aren't fun, but we've all done them. We've all gone through them. But yeah, we would appreciate if you filled in the feedback form, and we'll wait for you guys to respond.
And if there's any more questions, just, I don't know if everyone's watching on YouTube, but I assume so. You can put them on the chat there. Cool. I don't think there's any questions. And just to say, if you do the feedback, there's a section for a certificate at the end as well. To register your attendance. That might be useful for you guys. But yeah, I don't think there's any other questions or anything. So
Perfect.
cool.